So why are we interested in this group? The reason is right here on this slide. So they're now the group, the grey bars on the slide, they're now the group with the highest rates of suicide in the UK, men in their 40s and 50s. And one of the things that's quite interesting is if I'd been sat here talking to you 20 or 30 years ago, it wouldn't be this group I'd be talking about as having high rates of suicide. It would have been this younger group in their 20s. So 20 to 30 years later, it's not the group in their 20s I'm talking about, it's the group in their 40s and 50s. And part of what might be going on here is something we call a cohort effect. That group of younger men carrying their vulnerabilities with them as they go into middle age. So the cohort effect, and we might pick up possible reasons for that during the discussion. The other thing about this slide, of course, is the much higher rates of suicide in men than women. The grey bar there is the rates in men. The dark bar there are the rates in women. 3 times as many men in their lives as women. So that's why we're interested in this group. Why do men have higher rates of suicide than women? Well, part of it is probably to do with the methods that men use. When men hurt themselves, they tend to use more dangerous methods to do so. But part of it's also to do with the risk factors that men have. So this is a recent systematic review from colleagues in Glasgow, and I like it best of all because of this thing. It's called a bubble chart. What's the bottom line? Well, bottom line is of all the studies that have been published, here are some of the kind of common risk factors that have been identified in studies, things you might expect: alcohol and drugs, being unmarried is a risk factor for men, and psychiatric illness, particularly depression, increases suicide risk in men. So there's some of the, if you like, the risk factor reasons for why rates might be higher in men. But what part of the story also is help seeking. So there lots of researchers identified men perhaps not seeking help as readily as women, perhaps having more negative attitudes towards mental health, and our own work showing that in men sometimes the economic factors might be more important than the clinical ones. So we've got the risk factors, we've got help seeking, but the policy response has been good, I think. Men in midlife have been identified as a policy priority in the suicide prevention strategies in the long-term plan, and also in the quality improvement program that we're working on with many of the people actually who are on this event, on this call. You work with us closely, really trying to implement the evidence into frontline services. And men in midlife, middle-aged men, are one of the 3 priority areas in this quality improvement program. So lots of activity in the area of priority group. So what were we trying to do in this study? Well, in this study we were looking at, we wanted to identify the characteristics of middle-aged men who died by suicide, thinking about specific events, thinking about clinical factors that might have been implicated, thinking about how they used support services, and actually making some clinical recommendations to help strengthen suicide prevention. So the important point here is this was a study of all middle-aged men, not just middle-aged men in contact with mental health service. So unlike our report, this is a study of middle-aged men in the general population. So this is what we did. Basically, we went again to official statistics. We took a random sample of men who died, and then we obtained lots of information on those individuals who died, mostly from coroner's reports, but also from police, criminal justice reports, NHS data as well. And then our great research team examined all that information in detail and extracted the relevant information. So a detailed study, but a general population study. We carried it out for deaths that occurred in 2017. So we had a full calendar year. During that year, around 1,500 men. Again, Lewis has talked a lot about the shocking toll here, and each of these behind each of these statistics is an individual with a family. We never forget that. And we selected 20% of those men to look at the antecedents in detail, and we actually got information on a large proportion of those. So for 80% we had relevant information. So what did we find? Well, if we think about the known risk factors, first of all, so some of the risk factors in that review, we're looking at people's marital status. Of the men, about 40% were single, and a further 20%, 21% were either divorced or separated. So, being unmarried, an important factor here, as was the other factors, so alcohol and drug misuse in almost 50% of men who died, affective disorder, so that's both depression and bipolar affective disorder in about 30%. So these figures are about between 2 and 4 times higher than what you'd expect in the general population. So they are, although this wasn't a risk factor study, these are likely to be risk factors. So confirming, what other studies have found, but also finding some things that perhaps we weren't expecting to find. So 1 in 5 of these men in midlife who died by suicide had a history of violence. And in 1 in 10, it was a history of domestic violence, and a further 7% were actually the victims of domestic violence. So 10% were perpetrators of domestic violence, and 7% were the victims of domestic violence. A third of the men had experienced bereavement, most commonly parental bereavement, but 1 in 6 of these individuals had experienced suicide bereavement. Rather interestingly, rather like the in younger people, the data Lewis presented earlier, 15% there was some evidence of suicide-related internet use, and in the majority of these cases, it was searching, searching for things like methods of suicide. 15% suicide-related internet use, and over half of men had a physical health problem. So those are some things you might expect, some things you might not, but also a combination of long-standing risks, so things like family history of physical or mental illness. We've already heard about the potential very negative impact of early childhood experiences. So 3% having experienced negative experiences in childhood, another 4% having experienced some form of abuse. So important factors. So these long-standing risk factors, but also with the long-standing risk factors, more recent events. So interpersonal problems with families and relationships in over a third of people, but also socioeconomic recent events. That's come up in Lewis's talk as well. Almost a third had housing problems as a kind of recent event. Almost a third had financial problems, and in half of these people it was actually related to gambling. I know gambling's come up in the chat and in some of the Q&A. So about half of the people with financial problems had problems related to gambling, but also another quarter of people had problems related to work. So the socioeconomic factors were really important. What about help seeking? Well, help seeking, one of the stories out there is men don't seek help from services, but in fact, 90% of people had some history of service contact at some point. So only 9% had no history of service contact. And in 2/3 of men who had died, that contact had been fairly recent, it had been within 3 months of death. And in a third of men, it had been in the week before death. And a wide variety of services, 8 out of 10 having seen their GP, half having seen mental health services, half having seen mental health services, the emergency department, the justice, criminal justice system, third sector. So, lots of different agencies who they may have come in contact with. And about a fifth of men were in contact with multiple agencies. Just thinking about something we've talked a lot about in recent years, and it's risk. So of the sample of the over 200, about in about 70, just under 70, there was a rating of risk documented that we could find. But what's interesting is in 80% of these men who had died who had a rating of risk, the risk was viewed as low or not present the last time they'd been seen. So we've talked about the low risk paradox a lot over the years, but let's just have a look at these men who it was documented they were at low risk. 2/3 had a history of alcohol and drug misuse. 70% nearly had a history of self-harm, and 70% had expressed suicidal ideation or intent. So you look at that and you ask yourself, are these really low risk men? What's going on? Is it simply that the risk has changed? Is it that our risk assessments aren't fit for purpose. I mean, it might be a bit of that, but this is probably another example of how certainly mental health services risk barometers kind of are reset. So basically everyone who's seen by mental health services, many middle-aged men are at high risk, but if you like, we kind of tend to downgrade the risk. But again, we may pick that up in the discussion. Just very quickly, just kind of what are the take-home messages? I mean, one of the take-home messages is that the risk factors are both long-standing and more recent. So we talk about this model of cumulative risks. So you've got long-standing risks from childhood, you've got things that happen to you through your life, and then you've got, if you like, recent stresses and antecedents. And if you think about the prevention messages, they're different at each of them. So, you know, family and parenting support, economic kind of mitigation effects and access to services, and then ready access to crisis support. So this model of cumulative risk. But I mean, one of the things that really for this study is that rates of contact were higher than we expected, and one of the things we, I think, need to move away from, of course, we need to be in touch with the men who aren't in touch with the services, and I know many of you as part of the quality improvement work are doing brilliant things to get in touch with men who aren't in contact. But for those who are, we really need to make services fit for purpose. So it's no good, you know, that they're in contact. We need to engage men. We need to make them services fit for purpose. And again, we might pick up how we do that in the discussion. We need to kind of adapt interventions to suit men's needs. There's messages in the report. There's much more detail in the report about safer prescribing. Psychological therapies need to be suited to their needs. So 5% of men who died were had received psychological therapy, were receiving psychological therapy. 50% receiving antidepressants. You might argue that that's not an appropriate balance. So thinking about how we can tailor psychological therapies to men, and also this idea of, you know, recognizing risk and responding appropriately. There's no such thing really as low risk. It's about providing something for everyone. Other things, again, more detail in the report, providing bereavement support for the 1/3 of men who are bereaved prior to dying by suicide. Thinking about online safety. So online safety isn't just about young people, it's about people across the lifespan. But also thinking about prevention requiring a range of socioeconomic interventions. I've talked about the role of deprivation and wider interventions as well. So, you know, that high proportion of men who are either perpetrators or victims of domestic violence. So